Good morning. It's a great honor for me to be here. I will try to deal with this topic, the fetal malposition and malpresentation in labor ward. Fetal cephalic malposition are those conditions where the occiput is not anterior in labor, so posterior or transverse. And usually we have been taught since our medical school to assess the position by digital examination, evaluating which type of fontanelle is just behind the pubis. But we have learned, this is a paper from the group of Professor Nicolaides a few years ago, that our accuracy in the clinical diagnosis of occiput position is poor, with an overall rate of error, especially before important decision, such as instrumental vaginal delivery, in the range of 20-25%. We have an alternative that is assessing the fetal position by the use of transabdominal ultrasound, and actually, there have been two randomized controlled trials which have compared the accuracy of digital examination versus transabdominal sonography in the diagnosis of fetal position. The first trial comes from Dublin. They have randomized half of the patient, 257 in a group, where the diagnosis of position was done, a digital examination before forced to vacuum. The second group, where the women were allocated to standard care plus transabdominal sonography for position, and they've discovered that the incorrect diagnosis of fetal position before vacuum forceps was much more likely when the woman was submitted just to clinical examination. 20% of error compared with 1%, 1.5% with ultrasound. Similar result from this Italian randomized controlled trial that I've coordinated, the response to trial. More or less same design, women that were about to be submitted to a vacuum extraction, randomized in a group that just had vaginal examination versus a group that had vaginal examination plus abdominal ultrasound. And again, the rate of error in the group that was submitted only to vaginal examination was much higher, 13% compared versus 4%. There is a group that have a spontaneous rotation. This may explain why we have a perfect diagnosis also with ultrasound. Regarding malpresentation, these are conditions where the fetal head is somehow deflects. Classically, in the textbook of semiology, we have three varieties: synciput, which is the milder type; brow, this is compatible with the vaginal delivery and deflection of 3/3 face presentation. And diagnosis is usually based upon clinical examination, and there are no series regarding a comparison between clinical examination versus ultrasound in the diagnosis of malpresentation, but we know that intrapartum ultrasound may visually confirm clinical finding or spot a cephalic malpresentation that has been overlooked at clinical examination. This is an example on how ultrasound, transabdominal ultrasound, may assess fetal head attitude and may diagnose the three varieties of classical cephalic malpresentation, so synciput, brow, and face, in both positions, so anterior position or posterior position. Interestingly, we have demonstrated that apart from the classical varieties, we can measure and quantify even small degree of fetal head deflection, and we have introduced this parameter that for occiput anterior, occiput transverse position we have called occiput spine angle. The larger this angle, the more flexed is fetal head, so the more favorable fetal head attitude. For the occiput posterior position, we have measured this angle between the chin and the chest. It's called chin-chest angle. In this case, the larger this angle, the more deflected is fetal head. So, when the correct diagnosis of fetal malposition and malpresentation in labor matters, we have actually two contexts. The first is case of prolonged labor, and the second is before an instrumental vaginal or a fetal extraction in the second stage is needed. I will deal with the first part. So this is a study that we have conducted and published very recently from my former research group in Parma with other colleagues from other centers. We have recruited almost 130 women with a prolonged first stage of labor, and we have assessed transabdominally fetal head position and we have assessed the degree of flexion of fetal head by measuring the occipital spine angle for occipital anterior, occipital transverse position, and chin chest angle for occipital posterior position. We have also measured the fetal head station by transperineal ultrasound, measuring head perineum distance or angle of progression. And we have compared the outcome of these fetuses. So this is the transabdominal measurement of the occipital spine angle in the occipital anterior, occipital transverse. This is again the measurement of the chin chest angle in occipital posterior fetuses. Well, interestingly, looking at the data, we have found that in a multiple regression analysis, the degree of flexion or deflection of the fetal head, together with the station, were the strongest and independent predictor of the chance for this woman of achieving or not a vaginal delivery. So the degree of flexion matters together with the station when we are predicting the chance for a woman who is stuck in the first stage of labor to achieve a vaginal delivery or needing a cesarean delivery. This is an interesting sub-analysis of this study. We have only focused on women with the non-occiput posterior position. Interestingly, you can see on this slide, there is a linear relationship between the station and the degree of flexion of the fetal head. You see that the wider is the occipital spine angle, so the more flexed the fetal head, the lower is the station in terms of wide angle of progression or short head perineum distance. This relationship is true for the vast majority of these fetuses, but there is an exception. You see encircled in red, there are cases that do not follow the distribution. These are cases that we call statistically outlier. There are cases where the fetal head is well flexed, but the fetal head station remains high. That means that the angle of progression remains narrow or the head perineum station remains large. And interestingly, we found that these outlier cases that were all submitted to cesarean delivery were combined with a higher ratio between the birth weight and the maternal height. We decided to focus on the occipital anterior fetuses, and we found that most of these fetuses with this very well flexed fetal head and higher station showed a transperineal sonography signs of labor obstruction. That means big caput and molding of the suture. And using a ratio between a favorable head flexion and an unfavorable station, we were able to predict the vast majority of cesarean delivery. Based on this concept, we have developed this sort of algorithm for fetuses for women who are stuck in labor with a labor arrest. Whenever we have a woman with a lack of progression in the late first stage of labor, what we suggest is first of all to assess the fetal head position, then to assess the degree of flexion of the fetal head. When the fetal head is deflexed, that means that the occipital spine angle for occipital anterior, occipital transverse fetus is below 109 degrees, it is likely that the cause of dystocia, the cause of labor arrest, is a cephalic malpresentation. When the fetal head is well flexed, but the fetal head station remains higher, we have an unfavorable ratio between the fetal head flexion and the station represented by angle of progression and head perineum distance. And especially if we have also signs of obstruction, that means molding or caput, we should suspect a cephalopelvic disproportion. While when we have favorable flexion and low station, maybe it's just a matter of suboptimal uterine activity. So we may use oxytocin because we probably will sort the case of labor arrest. These concepts are contained in this editorial, was published just a few months ago on the on the special issue of Age on labor and delivery. So labor arrest is mostly due to poor fetal head descent, malposition and malpresentation or true cephalopelvic disproportion are the leading cause of lack of descent, and intrapartum ultrasound may be reliable in identifying this condition. This is the second context where we need to know for sure if there is a malposition or malpresentation, and is the fetal extraction in the second stage of labor. This is a series of a few years ago showing that the non-occipital anterior position was the stronger predictor of a failed instrumental vaginal delivery. This is a sub-analysis of the randomized IDOS trial from Dublin, showing that the suboptimal placement of vacuum or forceps was associated in the vast majority of cases with a fetal malposition, occiput posterior, occiput transverse. Why an occiput posterior position made our life difficult in the setting of instrumental vaginal delivery? We have actually two possible explanations. One is that the fulcrum and deflection point in the vagina is higher, is deeper, so the practitioner may be in trouble in reaching the right point where to place the vacuum. And the second is that the axis of traction is different because of the direction of fetal head descent. We should pull more posterior than we think. So I would like to show the study that was just accepted by AGEG. Is the only series so far on the outcome of vacuum extraction in sonographically confirmed occiput posterior fetuses. 100 cases, more or less, 98, just 4% of failure. Interestingly, the only parameter that was associated with the outcome of the vacuum extraction in OP fetuses was the head perineum distance, but not the angle of progression. And the reason, the question here is why for OP fetuses the head perineum distance performs better than the angle of progression? Usually the two parameters should change parallel. Throughout the fetal head descent, the angle of progression should become wider and the head perineum distance should become shorter on a parallel fashion. But this is not true for cases of occiput posterior position, because there is a different pattern of the fetal head descent for OP fetuses compared with occiput anterior fetuses. While the occiput anterior fetuses go downward, horizontal, and then upward, for the OP fetuses, the head direction goes downward and the mid pelvis even more downward before having the chance of flecting and going upward just to be delivered at the end. So if we compare the sonographic findings that we get for occiput anterior fetus, we notice that when we are at mid pelvis, we have a relatively wide angle of progression. The fetal head is at mid pelvis, in fact, which correspond to a short head perineum distance. While when we have an occiput posterior fetus, we may have a wide angle of progression because the fetal head is going downward towards the sacrum, and the second line, the tangent lines, makes this angle big and wide, but head perineum distance becomes large, so it's very difficult to put in the right place the vacuum when we have an occiput posterior fetus. So we think that in case of vacuum extraction, first of all, if the fetal head position is sonographically confirmed as posterior, probably the rate of failure became similar to the rate of failure that we have in the general population, maybe because we are aware of the fetal position and we may better place the cap and do a better traction technique. And finally, the head perineum distance between the two most popular parameters, head perineum distance and angle of progression, the head perineum distance probably represent the only parameter which is independently associated with failed and complicated vacuum extraction procedures. Thanks for your attention.